We're going to open 5 distinct case files today: anatomy of an ulcer, the Marjolin's mystery, venous ulcers, arterial ulcers, and finally, the trophic and diabetic foot. Section 1. Anatomy of an ulcer.
When the pressure kicks in during an exam or a rapid clinical assessment, just fall back on the room without a roof analogy. The straight vertical walls of your room, those are the edges of the ulcer. The junction where your room meets the adjacent room, so where the normal tissue meets the abnormal, is the margin. And you have got to remember the difference between the floor and the base. The tiles or marble you can visually see, that's the floor, where you might spot slough or pale granulation tissue. But the hard cement you physically palpate beneath those tiles, that is the base. Simply put, what you see is the floor, what you feel is the base.
You'll want to keep this master cheat sheet handy because the edge of the ulcer is your biggest structural clue. If you see a punched-out edge, your brain should immediately think arterial or diabetic trophic ulcers. Sloping edges, those point to venous ulcers or a wound that's actually actively healing. Now, if it's an undermined edge, meaning the ulcer extends further beneath a small opening, your main suspect is a tubercular ulcer. A rolled-out, pearly white edge is the classic signature of a basal cell carcinoma, also known as a rodent ulcer, which you'll typically see on the face. And finally, a raised, everted, cauliflower-like edge, that just screams squamous cell carcinoma.
Section 2. The Marjolin's mystery.
Let's dive into a real case. We have a 32-year-old male presenting with a rapidly enlarging leg lesion. If we track his symptom timeline, a massive red flag pops up. 12 years ago, he suffered burns to both lower limbs. Fast forward to 4 months ago, a small coin-shaped lesion appeared over the old burn scar, and it rapidly grew to 8 by 10 centimeters. But here is the critical clue. It shifted from being totally painless to exquisitely painful just 1 month ago. We're talking a 7 out of 10 on the pain scale, complete with bleeding and muscle wasting, because he literally refuses to move the limb.
That painless to painful transition in a rapidly growing lesion over an old burn scar? That almost always points to Marjolin's ulcer. The sudden onset of pain means the malignancy is now infiltrating the nerves. This is a squamous cell carcinoma. To confirm it, you've got to take an incisional wedge biopsy from the edge, never ever the nephrotic center. Now, interestingly, while this is a T4 disease due to adjacent structure involvement, it's actually N0. Lymph node involvement is surprisingly rare here because that old burn completely scarred the local lymphatics. The treatment plan? Wide local excision with flap reconstruction. Chemo and radiotherapy have very limited roles for this specific culprit.
Section 3. Venous ulcers. Moving down the leg, if you spot an ulcer on the medial malleolus, also known as the gator area, you are likely dealing with a venous ulcer, though they can pop up laterally if the short saphenous vein is involved. You'll want to watch for early signs like corona phlebitictasia, which is this fan-shaped pattern of thread veins. As the disease advances, you'll see pigmented margins. That's caused by hemosiderin deposition from broken down red blood cells. And if you spot that classic inverted champagne bottle appearance on the leg, you're looking straight at lipodermal sclerosis, where the underlying fat has totally obliterated, making the lower leg incredibly thin and shiny.
Now, for your exams and your clinical charting, you absolutely must memorize the new additions to the clinical CAP classification for venous disease. C0 is no visible disease, C1 is thread veins, but pay really close attention to C2, which is varicose veins, and the brand new C2R, which stands for recurrent varicose veins. Similarly, C6 is an active venous ulcer, and the new C6R marks a recurrent active ulcer. These R designations are game changers for tracking the chronic, recurring nature of venous hypertension.
When it comes to management, we rely on Bisgard's regime. That's all about the 3 E's: education, elevation, and elastic compression. To actually achieve that compression, assuming they don't have any underlying arterial disease, of course, you'll apply a specific 4-layer bandage technique. Layer 1 is orthopedic wool, Layer 2 is cotton crepe, Layer 3 is the elastic bandage, and Layer 4 is the cohesive bandage to hold the whole shebang together. Remember, you only use antibiotics if there is an active infection. But you can use the drug pentoxifillin to reduce blood viscosity and get that flow improving.
Section 4. Arterial ulcers. These patients will often give you a history of intermittent claudication that eventually progresses to rest pain, and you'll find absent arterial pulsations. Because of this, before you ever apply a compression bandage to a leg ulcer, you absolutely must check the ankle brachial pressure index, or ABPI. A normal ABPI is over 0.9, which means it's safe to apply that 35 to 40 millimeters of mercury compression. But if the API is under 0.5, compressing it will drastically worsen the ischemia. You have to revascularize immediately via bypass or stenting before you even think about managing the ulcer.
Section 5. Trophic and diabetic foot. These wounds are brought on by a pretty lethal triad: high tissue glucose that just invites infection, microangiopathy that starves the tissue, and neuropathy that completely masks the damage. Listen to this terrifying reality of neuropathy. These ulcers, which you'll often find on the ball of the great toe or the heel, are so profoundly painless that a patient can literally sustain a rat bite in their sleep and feel absolutely nothing. A trivial injury goes entirely unnoticed, and suddenly a massive punched-out, non-healing ulcer develops simply because the body's natural alarm system, pain, has been totally disabled.
Here's a stat you cannot forget. For every 1 gram % rise in HbA1c above the normal value, the patient's risk of developing a diabetic ulcer skyrockets by 20%. So blood sugar control isn't just about general internal health. It is directly, structurally tied to saving the patient's limbs.
As a clinician, you've got to grade these rapidly. Stage 1 is just inflammation with no actual breach. Your goal is to catch it right here with strict glycemic control, antibiotics, and rest. Stage 2 is superficial, and Stage 3 is deep. Both of those require debridement of dead tissue, and they often respond incredibly well to negative pressure vac dressings. But if they reach Stage 4, osteomyelitis sets in. Vac dressings will no longer work once that bone is infected, and sadly, these patients almost inevitably land up with an amputation. This is exactly why daily foot inspection and having someone else cut the patient's nails is absolutely critical. Let's lock in those rapid-fire clinical recognition skills. Arterial ulcers, they scream with pain, they're found distal to a vascular block, and they have sharply punched-out edges. Venous ulcers, they slope at the gator area, feature pigmented margins, and cause a heavy, aching discomfort. And diabetic foot ulcers, they silently punch out the heel or toe, completely devoid of pain due to that neuropathy. And always keep in mind, up to 30% of patients can have concomitant arterial and venous disease, so be on your toes for atypical presentations. From the sheer scale of the Grand Canyon to the microscopic obliteration of fat in lipodermatose sclerosis, you now have the ultimate field guide. Take these clues back to the clinic, look closely at the edges, the margins, the floor, and the base. Never stop investigating the full story behind those symptoms. But I'll leave you with this one question to think about. The next time you examine a patient, will you just see a wound, or will you read the story the ulcer is trying to tell you?